Safe sedation here, or safe administration of sedation. So let's watch here. Quite educational for all of us. Just check it out.
He fills the syringe with propofol, and it takes a few moments just because you have to go through this process. Okay, he then attaches this to the infusion tubing. If you could please stop. This is special tubing because it's what is called narrow tubing. The importance of being narrow tubing is that the tubing is so thin that there is probably less than 1 milliliter, 1 cc of propofol in the entire tube. Why is that important? That's important because that way any change in the infusion rate is instantly seen by the patient as a change in the tubing. Tubing that is quite wide can have problems because it can expand and contract. And if you push on it, the tubing actually has what we call compliance. And so there's a delay potentially in transmitting a change in rate. So for syringe pumps, we use this narrow tubing so that there's precise control of the drug that the patient is seeing. Please continue. So he attaches it to the tubing, and then he has to push all of the air out of the tubing. That takes a few moments. So this is not a trivial task. He first moves the air to the top of the syringe, and then over the next moment, he's struggling to get the cap off. That one was glued on. Not really. He then pushes He then pushed the air all the way through so that the tubing was only filled with propofol. Now he has the syringe, he has the tubing, now he has to put it into the pump itself. And then load it into the infusion pump, if you may continue. So this is a syringe pump. As you see the pump, that piece that's moving back is what is going to push the syringe forward in just a few moments. The syringe is placed into the pump. It is locked into place, shown here so that it can't move. And then the tubing is brought forward. Now he's going to program the pump. And so he goes down here and he's going to select the kind of drug he needs. I can see the word analgesic. I don't think that's what he's going to use. He moves past cardiac, past other to hypnotic. Propofol is considered a hypnotic, so that is selected. Midazolam is the first choice, but that's not what he's going to use. He moves down instead to what is called propofol OR, OR meaning operating room. So this is the propofol operating room. He now enters the weight of the patient. So this is done through this keyboard. Again, this takes time and care to do this correctly. He's entered the patient being 70 kilograms. And now he sets the initial infusion rate. It currently says, well, he's in the process of setting it. And after he sets this, he goes through and verifies all the setting. He verifies the concentration of propofol at 10 mics per mil, and he's still working on the infusion rate. Okay, stop. You do all of this in the operating room to get everything ready, and then you go see the patient. Now, sometimes you might see the patient very early in the morning and then do all of this and then go back. But quite commonly, you get your room set up so everything's ready to go, and then you assess the patient. Either way, the point is you assess the patient. The anesthesiologist always interviews the patient. Even if the anesthesiologist has seen this patient many times before, the anesthesiologist will say, Mr. Jones, tell me, how are you today? What's happened since I last saw you? What are the changes? Because the anesthesiologist is responsible for knowing everything that is going on in his or her patient. The anesthesiologist also performs a quick physical examination. Not surprisingly, the most important thing, again, is the airway. Is there any suggestion that there's going to be any difficulty during this procedure in moving air in and out of the lungs. The anesthesiologist will also listen to the heart, also listen to the lungs, particularly if the patient is elderly or has reasons for you to think there might be either heart disease or lung disease. For example, if the patient has asthma, you'll want to see how their lungs are. This is done always before each procedure for every patient. There are no exceptions. Please continue. Following that, you obtain informed consent. Informed consent, you can stop for just a moment. Informed consent is one of those words that has several meanings. Some people think it's the document, the thing that the person signs. And it is that. That's called the informed consent. But informed consent is also a process. It's a process in which the physician, the anesthesiologist, the surgeon, the internist, the doctor in the emergency room, every physician has a responsibility to describe to the patient the risks of the procedure. That process is called the informed consent. Every physician is responsible for describing to patients foreseeable risks of the procedure. That is part of the process of the informed consent. Every physician is responsible for providing patients alternatives to the proposed procedure. That word, alternatives, is explicitly mentioned in written informed consents. That is part of the process. And finally, every physician is responsible for, obviously, clearly explaining what they're going to do. Here's the plan. And seeing that the patient's questions are answered. All of these are part of the process of informed consent. So it's not just a piece of paper. It's a process by which the physician presents the plan, the risks, the alternatives, and allows the patient to have their questions answered as well. So please continue. Dr. Hung explains the risks and the benefits and the alternatives to the patient, actually a family friend of theirs. And then says, do you have any questions? And the patient says no. So at this point, the patient signs the informed consent. Please stop. Informed consents are signed pieces of paper. They're signed because throughout the patient's hospitalization, one checks before everything, is there a signed informed consent? Because that documents not just a piece of paper, but that the process was followed. It documents that the process was followed for that patient. So a verbal informed consent is not binding. It happens occasionally in an operation where something might be discovered. And the surgeon said, well, we talked about it beforehand. And then the surgeon will always say, it's not on the written informed consent. The fact that the surgeon discussed something beforehand, if it's not on the written informed consent, they cannot proceed unless it's some sort of life-threatening emergency. So verbal informed consent is not recognized. It doesn't exist. Informed